Good morning. Is the mic on? Yes. I'm Jeff Cleaver, the Executive Director of the Business Healthcare Group of Wisconsin, and I'd like to welcome all of you this morning to our Delivering Value Series Symposium with Centivo. This is the fourth year of our Delivering Value Series Symposiums, and we're incredibly excited not only to showcase Centivo this morning, but the other Delivering Value Series Symposiums that we have scheduled, and also our annual meeting on June 21st, and even more importantly, our golf outing that support. We're changing the recipient this year, but our golf outing, I think it's on August 17th or 18th. And I would hope to see all of you at our golf outing, because all of the proceeds that we raise go to the recipient for the golf outing. I'd also like, and obviously I'd like to thank all of you for taking time out of your very busy days to join us this morning. And even more importantly, I'd like to recognize three individuals, and I'd like to ask them to stand up. Dennis Salentine from BMO. Dennis. Melissa Del Vecchio from Bemis. And then Charles Gasser from BMO, and Charles is behind the glass, and he makes the magic that makes this all happen. So thank you, and honest to God, thank you very much for us to be able to utilize your venue. It's simply incredible. So 2023 marks the 20th anniversary of the founding of the Business Healthcare Group. As the title of the symposium suggests, over the past 2 decades, and in particular this year, we have seen that change is possible. And for those of you that have followed the Business Healthcare Group, you know that we are not afraid of disruption. And that has been a hallmark of our organization. So, as evidenced by the results, after the first year implementation of the high performance plan in partnership, and that's an incredibly important word, in partnership with Centivo, we consider the culmination of our efforts, which started with our executive steering committee approximately 3.5 to 4 years, and national practice leaders from 3 of the leading consulting houses as evidence of the success that we've been able to achieve to address both quality and cost. And we appreciate your interest not only in BHCG, but also Centivo and the symposium this morning. So today's agenda, my opening remarks, and then presentations by Ashok Subramanian, CEO and founder of Centivo, Drew Hodgson, and I think I just pronounced Drew's last name incorrectly. Sorry, Drew. Healthcare delivery, national practice leader, Willis Towers Watson, and then Pam Hannon, and who is the retirement and healthcare leader for GE Healthcare. And Pam plays a huge role in improving healthcare, not only in eastern and southeastern Wisconsin, but across the Midwest in the U.S. So we are incredibly fortunate to have Pam with us this morning. And then we'll move into a panel discussion, Q&A, and then closing comments. So I think we all are in agreement that the status quo is simply unsustainable. And that comes from health systems in our conversations. So when I came into this role approximately 7.5 years ago, one of the first movements that our organization made was to start to develop a better working relationship with health systems and provider groups. And why? Because they were in agreement also that the status quo was unsustainable. And there's no question that the brokers and consultants, trusted advisors to many of you as clients, are also in agreement that the status quo is unsustainable. And obviously for employers, when you look at the expense that they're incurring, and also even just as importantly, if not more important, employees and their dependents, and then finally the business community that the business healthcare group doesn't represent, right, all employers from a membership standpoint. But we feel that part of our mission is we want to be a good corporate citizen for the state of Wisconsin. So we are willing to move forward our initiatives for the benefit of those employers and businesses who are not our member employers. Now, the one thing that differentiates those organizations that I just highlighted is that are the traditional health plans. And it's our view, the Business Healthcare Group and the Executive Steering Committee, that there really is there's no support from the traditional health plans. And that has contributed to what? Very simple, that the status quo continues to be unsustainable. So I'm going to just do a compare and contrast between United Healthcare and Centivo. And for those of you that participated in our annual meeting, you'll recognize that I made very similar comments at our annual meeting. But the metrics that I'm going to go through now, to us, to the Business Healthcare Group, and to our member employers, are incredibly disconcerting. And it shows the heart of the issue that drives healthcare being unsustainable for all of those stakeholders that I went through. So UHC's total revenues were up 15% in Q1 of 2022 versus Q1 of 2023, from 80.1 billion to 91.1 billion. Incredibly, to us, again, incredibly unbelievable and disconcerting numbers. The next metric is even more disconcerting. Total profits up 16% from 7 billion to 8.1 billion. And if you think back to the COVID pandemic and the increase in profitability during that time, obviously this increase is even greater than that when you compare it with what occurred during the pandemic. And then compared to the first quarter of 2013, again, this is from Q1, UHC's revenues have increased 303%, while profits have increased 386%. And troubling to every one of you in this room. They haven't entered, right, the state of Wisconsin yet. But how many employed physicians or aligned physicians does Optum own or align with? 70,000. It's more than the VA. It's more than Kaiser, Permanente, more than HCA, more than or HCA Healthcare, Universal Health Services. And the question that those of you that have operations in Wisconsin should be asking you is, when are they going to move into Wisconsin? And what is that impact going to be on you? And when you look at the impact that this has brought to those communities that they have purchased all of these independent groups, obviously it's not good because they then control the market. This next slide really portrays both a problem and an opportunity. Many of you know WEA Trust and the Health Tradition Health Plan exited the Wisconsin health insurance market at the end of 2022. So we lost an option, right, for a health plan to place. And for you as trusted advisors, brokers, and consultants, you lost an option with WEA. Humana is exiting over the next 18 to 24 months. The question then is, who's next? So that's a problem. But we view there's an opportunity here. And that opportunity is to partner with Centivo, because Centivo can replace WEA and Health Traditions. They can replace Humana. And obviously, they are a solution for many of the other health plans that are currently in existence. And there's an opportunity to have Centivo gain market share. Contrast that to this, right? Optum, United Healthcare. Do you want, as the business community, for all of this money to be leaving the state of Wisconsin and to be going up to Minneapolis to feed the mothership? Wouldn't it be better for all of us for that money to stay here and to be utilized by health systems, provider groups, employers, and employees? And how can we do that? We can do that with the partnership with Centivo. There is an incredible opportunity here to change the dynamic in the state of Wisconsin. So in our view, the choice is clear. Fundamental change is possible. We have created the Business Healthcare Group has created fundamental change with the health systems and provider groups, Freighter, Ascension, Prevea, the Medical College, Children's, Pro Health, Pete Bacon, and other health systems and provider groups going up eastern Wisconsin. So change is possible. And then when you look at the BHCG-Centivo High Performance Health Plan, one of the key aspects is it's fully transparent. Same thing with our best-in-class strategic partner for PBM. Who is that? Centivo, fully transparent, right? As an employer, you have full access, if you're a Centivo client, to their contracts that are in place with health systems and provider groups. Can you get that with the other health plans? Absolutely not. What does that translate into? Full transparency. What are they providing? A primary care-centric model. Incredible results for 2022 that Ashok is going to speak to. Increased healthcare value in both quality and cost efficiency. And Ashok will also address better consumer and provider healthcare decisions. So there is a choice for partnership. And again, we do not use the term partnership lightly because there are only certain organizations that we believe truly will partner or will move forward in a partnership. And Centivo absolutely does that. And that is why the executive steering committee of the Business Healthcare Group selected Centivo as its partner, and also why it's moving forward with a primary care centered or centric solution. So I'll turn the presentation over at this point to Ashok.
Thank you, Jeff. It can feel a little hard sometimes to be optimistic when you see those numbers. One of the stats that I've been using a fair bit recently, and I know Drew is going to speak to this a little bit later, is CVS Caremark, for example, makes more profit from their PBM than from their 50,000 retail stores. United Healthcare is now the largest employer of physicians in America. I think it's important because at the end of the day, whether this is the right solution, others are right solutions, it's just important to know, because when we talk about affordability, and we'll talk about affordability, when we talk about quality, when we talk about transparency, the results that we have today in the system as it exists is not an accident. There are active beneficiaries of the broken system today. And what you saw on those slides that Jeff presented is that there are organizations, and bless their hearts, they have a right to make a profit, but they have found the cracks and crevices in the system that allow for those profits to be made in spite of the fact that deductibles are going up 3 times at the rate of wages, and that the share prices of the publicly traded stock carrier stocks has gone up 8x the number of those deductibles. So massive breaks in the system, and stepping back and thinking about how we can make them work is obviously why we're part of the solution. Jeff's hit a lot of these key points. The one other point I want to raise here, best, we're a convener. We're a catalyst for change. The real magic happens in the conversations between employers and providers. Employers as the purchaser of healthcare, happens, we play a small role. It's important to focus on, we're all aware costs are going up. We're all aware, although there's a quiet quitting happening now in our workforce of people lowering their participation in health insurance. That's an affordability problem. But on this provider side, we in our travels spend a lot of time talking to various systems all around the country, in communities just like here, as well, of course, our partners here in Eastern Wisconsin. And the commonality is stark. What most health system CFOs tell us is that the economic conditions for their organizations right now are as difficult as they've seen in 15 years, with one added dynamic. 15 years ago, at the last economic crisis, the workforce shortages, the fact that we were paying $50,000, $70,000, $100,000 in signing bonuses to recruit nurses, that labor dynamic was not in place. So it's a precious time where there is enough money in this system to fund everyone's needs. There's enough money to make sure that employers can control cost at a reasonable price. There's enough money to make healthcare affordable. There's enough money that providers feel like they don't have to leave their profession due to burnout and excess administrivia. But the way it's set up today is simply not working. And kudos to BHCG and the ESC for raising attention to those issues. So I want to spend a moment before we get to some of the numbers and results, and we'll spend a lot of time talking about this in the dialogue as well. And I know Drew and Pam will share their perspectives also. But at the end of the day, I think most of us who've gone into the business of healthcare, whether it's as a human resource executive on the provider side, as an advisor, or as someone who works in the industry as I do, down in our core, there are better ways to make a living. Let's face it. It's a tough business. You've got big actors. You've got, it's hard to make change sometimes. It's an industry, because healthcare is so personal and so emotional, that if you make a change and something doesn't go exactly right, you're more likely to get blamed for that change as opposed to getting credit or a fist bump if something goes well. So that on January 3rd, the ID card might have been missing one digit, but you're not going to hear on April 1st where someone had, sadly, an employee had a heart attack and or a spouse had one and the family got great care at a fair price they could actually afford. Those stories don't come up. But that ID card digit, oh my gosh, you're going to hear it within seconds on Slack, right? So it's important to remind ourselves, why do we do what we do? And I think we all share this, right? We have common ground around there's a way to do the right thing for all of our stakeholders. And so these are real examples on the next few slides of why we do what we do. And by we, I mean the royal we, I mean all of us. And so a great example is, a client who had high deductible plans because that's all they felt they could afford. $3,500 deductibles in a $18 an hour workforce. And admittedly, they had many members of their team who on an annual basis would cringe at the upcoming open enrollment meeting, who didn't want to walk in the room because they knew that best case scenario, it was bad news, and worst case scenario is horrible news. That the benefits are going to get worse, the costs are going to go up. What they said was the open enrollment meeting had become the announcement of the annual pay cut every year. So this is an example that I'm super proud of. It's an example where someone walked into the room and said, hip, hip, hooray. This was the first meeting in 10 years that I got good news. And the specific example, and there's scores of others, but the specific example was someone saying, I couldn't work effectively because I was worried about my son. I had to drop my son from my plan because I couldn't afford the step up in cost and the step up in deductible to have my dependent on the plan. And I tried to find a plan in the individual market and it was painful and it didn't work. But this year I was able to add back, and it was interesting to hear this word coming from an everyday worker, not someone who works in healthcare or benefits on a day-to-day basis. But she used the word that a lot of us use all the time. He was medically homeless. He was medically homeless and he's not anymore. I think we would all agree here in Wisconsin, we have great quality of healthcare, phenomenal providers, world-class care. We have employers who want to do the right thing. There's enough money to go around. We shouldn't have employees of ours feeling like their families are medically homeless when we know that there are solutions out there. But we can change that. On the employer side, this is a several hundred employee company here in Wisconsin that was concerned about the fact that their annual participation was dropping. And by virtue of their annual participation dropping, what was happening? Their risk pool was getting upside down. And this isn't an organization with 50,000 people that could spread that across. This was an organization where if you lost a few healthy people and picked up a few sick people, the numbers start getting a little dicey. And so year after year, despite cost shifting, despite traditional shopping, despite moving some pieces around, the hamster wheel was on autopilot. So what they were able to do was keep a plan that they had similar to what they've liked, add a plan that was richer, had the controls in place that we've talked about and will continue to talk about around making sure that your care journey starts with a great primary care team, making sure that we're maniacal about cost and quality being at the centerpiece of how we build that provider network. And what they were able to do was reduce cost, improve benefits, increase participation, which in their right-minded view was a positive, not a negative. It was not, oh my gosh, our costs are going to go up this year because a few more people joined the plan. It was, we now have a more stable pool and we have the ability to attract and retain a workforce that will be loyal to our organization because of the investments that we're making here. That's a win for the employer. And then on the provider side, some of you have heard this joke before, so I apologize because my jokes don't get better the next time. But my sister's a primary care doctor. And she has often said that if she had a mulligan, she should have been a veterinarian. Because at least the owners of vets pay cash and the patients don't talk back to you. It's a hard time in America to be a doctor, and it's a very hard time to be a primary care physician. You come out with medical debt. You're encouraged by your peers and others to go into specialties like ophthalmology or dermatology. We need those too, especially I do. My eyes are terrible. But there's not a lot of reward, either financial or non-financial, to go into primary care. Then you join practice. And oftentimes you have patient panel sizes that are too large. You can't spend enough time with your patients. You feel like you have to get them out of your office in 7 to 10 minutes. You have incentive structures and plans and other things in place that make you feel like at the end of the day, you're working for somebody else. You're a prisoner of the administration, as opposed to actually being able to do the right thing for the patient. So one of the things that we tried to put in place, and this will continue to grow over time, and kudos to our partners, and Jeff named all of them, so I won't repeat them, but kudos to those who are willing to say, I'm going to try something different. I'm going to try something different, even though on day one, the volume's not going to be what it is with a major carrier. And these partners have stepped up and done a phenomenal job at training staff, educating them about what it means to look for Centivo as an ID card, what it means to submit a claim, to manage a referral. One of the things that I'm most proud of is since the month of February last year, we have not had a patient be misidentified when they've walked into a provider's office. Kudos to the provider community for stepping up and doing what's right for the employer community, for the business community on that front. But what we can do is rewire the system. What we are doing is rewiring the system so that providers feel like they actually know the patients right up front, beginning of the year. Here's who I'm responsible for, and now I have the incentive to actually do right by them. So those win-wins tied to a model that is built and architected to be primary care first. Some of these concepts require conversation, communication, maybe the term change management with your employees. Some employees might have PTSD from 20 and 30 and 40 years ago of how it might have been to have a model that was primary care centered. But the reality is, it works. It works to bring people back into the system. It works to make sure they're not medically homeless. It works to have somebody that you trust. That person's a lot more coherent than I am. Testing. All right, we're good. So a couple of stats that I think are really quite astounding. And one thing I would just share with you, I think it's fair for anyone in the room, an employer and an advisor, to say, well, this is a year of data. This is some early adopters. The good news is this mimics data that we've seen in other markets. It mimics data that we've seen in larger employers and smaller employers. It mimics things that other organizations not named Centivo that share similar principles have done, like Kaiser and Geisinger and Intermountain Healthcare, others who've rolled out direct primary care models. So these are not unique to us, but they are consistent when you apply principles of a primary care centered model driving care into a high performance organization. So I think the key points that I would highlight, as well as one other one not on this slide. So the first is the increase in primary care visits. For years, we've all been asking ourselves, why is it that primary care utilization is going down? Why is it that I've seen carrier book of business reports that show as few as a quarter of a population having an annual preventive visit? Just a horrible number, to be honest. And there's a lot of reasons for it, but a big reason for it is the fact that when you put a high deductible plan in that covers a wellness visit but leaves exposure beyond that, what we've done is subliminally erode trust in that relationship with the primary care team. How many of you have had an associate who said, I thought I was going in for my free visit, but I just got this bill with several other things because they found a mole and I had a test? And we've all had that. We've all heard those stories. So one of the biggest things that we did is work with all of our stakeholders to make sure that we're going to say, let's define the site of service as primary care to be free. Let's do what we did in 2009 when we made well visits free, and let's do the same thing for sick visits. Let's do that for adults. Let's do that for pediatrics. If it's an HSA qualified plan, with a couple of our partners, employers in this room have, let's make sure that it's first dollar after that qualified deductible, that primary care is free. What that now does is take away that erosion of trust. That site of service is, I should see someone and get that guidance if I'm sick, just the same as if I'm well. Very important shift. That's driving the 29% increase. And I think any actuary in this room would say that that's good spent. There's a difference between an investment and an expense. That's an investment when we put more money into primary care. We're seeing the offset from the financial side, a drastic reduction of ER visits, a drastic reduction in inpatient admits. Two other data points I'll share for those of you who want to go into healthcare nerd land. So the first is on our inpatient data across the board. This puzzled us early on, but then we kind of thought through, got some outside perspectives, and it makes sense. One of the things that we see almost across the board is that our average length of stay when someone gets to a hospital actually is higher than a traditional benchmark. Why is that? How do you square the circle? The circle's generally getting squared because fewer ER visits mean fewer short stay, overnight, one-day inpatient admits, which means that when you're reducing the number of admits and you're basically keeping the people who should be in the hospital, your average length of stay is going up a little bit. So again, a good example of the money going to the right places. The other question we often get asked is, well, is this just meaning people have to go to a primary care, people need guidance to figure out where to go downstream on their specialists, they're not able to call Dr. Yelp or Dr. Google to figure out which GI doc I should go to, although they can do that for sure if they want on their own. Does this mean that people are getting less specialist care? And the answer is a resounding no. So actually, we're seeing more specialist visits. And that's something that, again, in all transparency, members of our team did not expect when we started this journey. There was somebody, a professor at the University of Michigan, Dr. Mark Fendrick, who's an advisor to us, and has long been, many of you may know him, he's long been steeped in value-based insurance design principles. He predicted that. He said, you will see more specialist utilization because what you're going to see is people coming out of the woodwork, having primary care, and realizing that they have untreated conditions. We've had some sad stories that have resulted. But the good news is these are people who, while sad that they had undiagnosed conditions that they were living with or family members were living with, are now getting the care that they need. A recent example of a client is an adult dependent who appears to have undiagnosed leukemia. Will now get the care that he needs. So the upshot of all of this is when you partner with the business community, when you work with providers to align incentives, when you have frank and honest conversations about the sustainability of the cost structure. We all know that there's great care at high quality here in the state of Wisconsin, but we also know that hospital prices have been high. When we partner with those stakeholders to say that we can create win-wins, it's not just about jamming on price. It's about finding ways to advance quality. It's about finding ways to take cost out of the system for providers. Classic example, chasing money on people who have extremely high deductibles with no hope of ever collecting. That goes away with reconstructed plan design. When you work closely with all stakeholders to say our fees and our compensation are going to be completely transparent, great things can happen. And these numbers and the range will always vary by type of company, where they are, where they've been, what kind of year they had, the relative clinical mix of their population. But these are based on the bookends of the numbers you see are based on benchmarks by a large nationally well-known consulting firm, one of which is tied to organizations that are more aggressively managing their healthcare conditions, self-funded care management programs, targeted initiatives. And the one on the right is one that they would call more loosely managed, which comes out of populations that typically are on autopilot. And that reflects what we're seeing. We're seeing smaller organizations get the type of savings closer to that 30+%. We're seeing larger organizations, including some of the largest organizations in the community, who have said we were hoping and expecting about 10%, and we're seeing 20%. So it is remarkable when these things come together that we can achieve the kinds of results that we have seen. And I'll leave you just with a couple more thoughts, which is Centivo at the end of the day is organizing the program. We're not a pharmacy benefit manager, but, and I know Drew and others are going to speak to this, Jeff did as well, let's not lose sight of 20 to 25% and a faster growing proportion of most employer spend is on that pharmacy side. And without even getting into what's known as medical pharmacy and specialty and high cost biologics, and a Centivo client outside of the state is one of the manufacturers of these $1.5 million drugs. Like there's some wild stuff going on that is saving people's lives, but that most CFOs are not ready for. But there are huge opportunities in this area. And this is an example of a 600 employee client that was on a traditional carrier. And just on rebates, just on moving from a model where profits are subsidized by pharmacy rebates, moving towards a model where everything is passed through and the only compensation the PBM gets, in this case Navitus, longstanding BHCG partner, is through a flat administrative fee. Nearly a $90,000 increase in capture of the rebate by the employer. And oh, by the way, that doesn't even count the fact that that rebate capture is structured still around the fact that it's a lowest net cost formulary without spread pricing. So you're actually paying the actual cost of the drug, as Mark Cuban has famously marketed, as opposed to paying an artificial markup that's being adjusted by the drug company, by the PBMs. So I know Drew and others will speak to this. Is there any other part of your organization at the 600 employee size, or with one flip of the switch, without changing experience for the member, for the employee, is dropping $90,000 to the bottom line? I wish I had more of those in my organization. So with that, appreciate the time, appreciate the support, and I'll turn it over to Drew.
Thanks, Ashok. And thank you for having me here. I really appreciate it. This is actually my first time to Milwaukee. I'm from New York originally. I'm with Willis Towers Watson. I'm going to take this to more of a macro level, right? Because I'm a national consultant, so I look outside of just areas like Wisconsin, but all across the country, mostly for larger employers. But more and more, to Ashok's point, we're starting to talk a little bit more about some of those mid-market type employees around the country. But I want to start with, and this was not planned, that I had this slide completely separate from what they were talking about. It gets to exactly what Jeff and Ashok were talking about the state of the market today. And if you look on the left-hand side of this chart, you can look at the commercial market share in the market today, as it is today. United Health Group on the bottom there with the 15% that we were talking about a little bit earlier. 31% represents all other blues other than Anthem. And then 14% there at the top with other types of carriers, et cetera. What this is showing you is that very heavily weighted across Buka, which is Blues, United, Cigna, and Aetna. But there's room in there for other types of solutions. And to Ashok's point, a lot of the major carriers have not been moving the needle enough from a value-based care perspective, from a local perspective. I can tell you from my experience, a lot of them have doubled down on the broad network concept and really tried to just drive discount. And anyone who knows me knows that I think discount it's nothing. It doesn't mean anything, right? If you look at the overall cost of care, it's very different from what a discount result would look like. But on the right-hand side is where I find this really interesting, and this gets to the point that Jeff was talking about, is where's the revenue coming from across the major carriers? So I'm going to focus on the four right-hand ones in particular. And you can see in the far right with United Health Group, you can see clearly they're the big player in the room. This is from 2021. But the darker blue is the insurance arm. So that's your health insurance. That's self-funded, fully insured, Medicare, et cetera. That's where that revenue is coming from. The blue component is the pharmacy, and the purple is provider, right? So they've got a slightly different model that they're dealing with around the providers, which Jeff was talking about, is they're starting to buy up providers around the country and create models around those. When you look at CVS and Cigna, they're becoming PBMs. I'm not going to throw anybody under the bus as far as carrier. I'm going to be a consultant, so I'm going to be careful about who I criticize and don't criticize when it comes to the carriers. But the bottom line is when I have a finalist meeting today and Cigna shows up, they lead with pharmacy. They come as a PBM. CVS, Aetna, same thing starting to happen. That tells you they see where the revenue is going to be in the next few years. That's where it's coming from. And then you see that green, which is other. For CVS, Aetna, that's retail. That's clinics. Again, driving money into the PBM. So that's where they're doubling down, and that's what they're trying to work towards. And we see that time and time again in the consulting community as these people come in to do their finalist meetings. I want to talk a little bit about affordability and inflation and the pressure we see in the next couple of slides here. This is kind of a little bit of an eye chart. There's all kinds of things going on in this one, but if you look at the dark purple, that is salary increases since 2007. It's really flat. How many times do you see it's 3%? It's 3%. It's 3% every year after year after year. You're starting to see that tick up in 22 and 23, and there's a number of reasons for that. Tight labor markets, a lot of issues through the pandemic that's starting to really actually try to make a difference in wages. The light purple is that trend. And I've stolen this comment from Ashok many times about the annual pay cut. And I started using that exact comment to clients sometimes because it feels that way. Typically, almost every single time, healthcare trend is significantly higher than any salary increases. But the part that I find interesting here is the line, which is inflation, just general CPI. And you can see the way it's just sort of stayed relatively low for many years, but you see that huge spike 21 and 22. Numbers just came out recently, it's dropping again. So it seems like we may be out of the woods a little bit in inflation, but it also depends on where we're going to go from a recessionary perspective as well, of what we might see. But the reason why I bring this up, you see the 2023 projected trend getting very, very high, above 6% for commercial health plans. Healthcare trend lags inflation traditionally. What you see in general inflation is typically going to happen 12, 18 months, 24 months later. That's why you're seeing that 2023 spike in what most of the consulting firms out there agree is going to happen to healthcare. And honestly, I think when we look at 2024, unless we head into a recession, which could change the result, we're going to start seeing trends get very, very high over the next couple of years. So something that I think is very, very concerning that makes employers realize that they have to do something to control this going forward. The other component of this that I think is concerning and has been concerning for a while is the pressure we've seen sort of during the pandemic. There's a number of things that have hit the market. I'm sure Wisconsin is no different from anywhere else in the country as far as seeing cost, utilization, and virtual care. And yes, I'm calling virtual care a pressure, and I'll explain that in a second. The cost pressure we see is coming from a number of different areas, right? So provider consolidation. We've had that problem for a long time. We know that's been going on for the last few years, or the last decade of that happening. But during the pandemic, what we've seen around the country is those provider systems that really did not embrace value-based care. They were still fee-for-service, those physician groups. Their revenue just dried up, and they became under a huge amount of pressure, and that creates the potential for more takeovers, more consolidation within the market. And we've seen that start to happen a lot more. And as anyone will tell you, as any market, anywhere in the economy, as consolidation happens, prices go up. The other part of this is contract negotiations. And we're seeing it all over the country. And you probably can't open your mail anymore without seeing some health system is in danger of falling out of network because they're in a fight with United Health Group, or they're in a fight with Aetna, or they're in a fight with Cigna or the Blues. Honestly, and with risk of going the opposite way here a little bit, some of them are justified. We saw in New York an argument between United Health Group and Montefiore, where Montefiore were asking for 30% increases. And United Health Group is like, no, we're not going to do that. In the court of public opinion, the insurance company is the bad guy. End of story, right? If you go onto LinkedIn at the time and you saw these posts, 99% of the comments were against United Health Group. Now, some of that's justified, I get it, but some of it's not as well, right? There's a little bit of give and take in this all over the board. But the bottom line is that the health systems are the heroes from the pandemic. It's very hard for an insurance company right now, and has been over the last couple of years, to really make that argument against them. So we're seeing that cost pressure a little bit too as those revenues start to go up. And it comes down to basic supply and demand too, right? We have more demand than we have supply today. Again, putting those costs up. From a utilization perspective, health systems lost a lot of revenue. We know that. There is a fear, and I'm a firm believer in the United States, I think in the UK where I'm from as well. In fact, most of the Western world, we overutilize medical care. We overinsure, we overutilize medical care. It's what happens, right? A lot of it in the United States is driven by the fact that we're a for-profit health system in general in this country. But we do find that appropriateness of care factor is a big component of what we do. And that gets to why having high value primary care is so important, because it's the first step towards, are you getting the right treatment at the right time at the right place? My fear, of course, is because of the lost revenue and what's happened with the health systems, there's even more pressure on them from the C-suite of these systems sometimes to drive revenue, right? I think we're kidding ourselves if we don't think that health systems act like any other large corporation where they're ultimately trying to be profitable. So with that lost revenue, trying to build that lost revenue back, there is a danger of overutilization, especially when you're looking at things like broad networks. And of course, we've got the pent-up demand as well. So we started to see that come through. I think it's continuing to remain high, a lot of the utilization, especially for elective surgeries, those types of things are starting to come back. But that again, that pent-up demand creates that increased utilization, increased demand, and therefore the supply creates a problem. Now, the virtual care, the reason why I consider this a pressure is we saw crazy increase in virtual care throughout the pandemic, as you know, as we needed to. It was remarkable how quickly the market could move when it needed to, and it did. And in general, that's a positive. But there is that danger, unchecked, that it will actually raise costs. And I'm sure we've all seen the concept of, is it in addition to care? Is it replacement to care? Are we going to get overutilization if we're not managing the virtual care in a really good way? The other part of it is healthcare disparities, which is something that is close to my heart. I do a lot of work in social determinants. I do a lot of work in climate change, those types of things that are driving health outcomes and driving what's happening in communities. And I've done a lot of work on healthcare disparities, particularly between underserved communities, rural America, urban America, et cetera. Is that what's happening out there? And what you saw in education during the pandemic, I fear happens in healthcare too. Areas like where I live in Westchester, New York, my kids did great during the pandemic. They had their laptops open on the dining room table. They were good. They've got broadband. They're happy. They've got their smartphones. There are parts of the country where 1 in 4 people don't have access to broadband. Are we going to create even more disparities in healthcare with virtual care? Overall, it's a positive, but I think we have to be careful and make sure that we provide the care where it's needed and meet the member where they are, rather than forcing them into some of these buckets that you can potentially force them into. Now, that's all sort of the negative of what we see coming. But the bottom line is, as Ashok was talking about, it's the solutions out there. There are things we can do to change what all of that negativity going into the next 2 or 3 years, right? Status quo is unsustainable. I think you've heard that now twice or 3 times since we've been here. I'll change that and say the status quo is the highest risk option. That is the riskiest play you can do, is to do nothing right now. You know these costs are coming up. You know that the healthcare bottom line is going to grow. All of those components are happening. So now's the time to say we have to take the whole pie and shrink it. The days of cost shifting is over. The days of sort of just moving deductibles and moving out of pockets it's just not sustainable anymore. To Ashok's point around affordability and bankruptcy and the cost of a $3,500 deductible for a $30,000 employee is just not sustainable anymore. But the opportunities in the markets exist, right? And you see the list on the bottom there. From high value primary care, which we've talked about already quite a bit, network structures, which we've talked about a lot, virtual care, navigation, advocacy, value-based strategies. How do we bring all these components together and think about things locally? And that's something that certainly at WTW that we push as much as possible. Certainly I do, and within my team that I work with, is to start thinking about healthcare at a local level. It's very, very important. And I get very disheartened when I meet with a client and they say, no, I've got to offer this solution to everybody in my organization. End of story. It has to be the peanut butter approach. And the bottom line is that's just not true. You may, you have travel benefits or commuter benefits in certain markets. You have healthcare. You have like gym memberships at certain markets if they're there. There are other benefits out there that are different from market to market. Ashok and I have joked about this before. It's like I've had that conversation and asked them if they've got Kaiser, and they say yes. I'm like, you have Kaiser. Why can't you do the same thing over here? It's the same thing. So it's a challenge. We brought up the concept of disruption. I think Jeff mentioned that we like disruption. One thing I would love people to think about is stop using disruption as a bad word. It is not a bad word. It's a very strong word. And there is so much positive disruption in the market. If you think that taking a patient and putting them into a high-value primary care and moving them over to a very high-quality surgeon to get the better outcomes possible, if they're a cancer patient or whatever they may be, if you think that's negative disruption, then you're wrong. That's a positive thing. And I think we have to start thinking about things a little bit differently. As I said, if you stay where you are and don't disrupt, then we're going to deal with these kind of increases for a long time. I have a couple more slides. I want to talk about a little bit what employers are doing around the country now. And a lot of it is actually reassuring about what they're thinking about and where they're going. This is from Willis Towers Watson's 2022 Best Practices in Healthcare survey of large employers out there. And we asked them a lot of questions around healthcare delivery, what their current structures are, and what their future plans are going to be in the market. I want to focus on this one, the Centers of Excellence component, right? Because Centers of Excellence to me is just another piece of the network. I work very closely with a lot of the carve-out COE vendors and the carriers, what they're trying to do to try to steer care into high quality surgical centers, those types of solutions. And you see the use of Centers of Excellence within the health plans is growing. That's a story for a whole other day of what the value of a COE within a health plan. As far as the carve-out vendors, they're starting to grow. They're starting to gain more and more traction as they go down to the physician level, starting to get to surgeons, starting to get to prospective bundled arrangements, getting to true value-based care. You're seeing that grow. We're now considering for 2024 another 16% on top of the already 10%. So 1 in 4 employers now either have or are going to be planning on putting in place by 2024. That's a huge number, 1 in 4. When only a few years ago, that would have been less than 10%. Navigation, again, similar story. Digital support, similar story. If I go to this, I'm only going to focus on the top left and the top right on this one. The part that really gives me a lot of hope is the top left. This is what I wanted to see, and this is what we are seeing, about offering a narrow network of higher quality and or lower cost providers. To me, that or should go away, should be and, but that's how the question was asked. There are a lot of sort of narrow networks out there, maybe not focused on quality, but just lowering cost in general. It's been hovering around the same level for a long time. A lot of employers would kick the tires, have some meetings, do nothing because they're afraid of disruption. That jump for 2024 is huge. A lot of that's been driven by what I've talked about. A lot of it's been driven by what the consulting community is talking about, thinking about things locally and being able to offer these types of plans to their employees. A lot of times they're not a full replacement, they're a carve out, right? They're saying we're going to go ahead and offer Centivo, or we're going to offer Aetna Whole Health, or whatever it may be in a market to our employees, and try to get the highest risk population we can to enroll in that plan, because they're the ones that we want to manage the best and get into these types of solutions. So up to 45% is really, really strong. And then direct contracting stayed relatively flat. You don't see it a ton. In fact, it dipped down in 22 and 23, and it's really still only at about 16% for 2024. Doesn't surprise me that much in this environment. And the reason I say that, and I was talking to Dave a little bit about this before we started today, that in a world today where the likes of Centivo exist, or some of the competitors out there, right? There's the Employers Health Network, there's Imagine Health, Collective Health trying to get into the space. There's a number of carve-out solutions now from a network perspective that I sometimes describe as off-the-shelf direct contracting. I sometimes argue that if those types of solutions had existed, would some of the Boeings of this world, or the Disneys of this world, or the GMs of this world, would they have done it on their own? And I'm not so sure they would. I think the opportunity and the administrative burden of doing it. So I think unless you own a city like Disney in Orlando, it is a lot more challenging, I think, to go into direct contract. And now the solutions exist to be able to go in a little bit of a different direction through that. So I'll end with this comment is that if you're an employer with a population across the country, I know it can sometimes feel challenging. You have pockets of population in 20 different markets, sometimes 1,000 people, sometimes 1,500 people. I encourage you to look very closely at each market individually. Look at the data, look at the claims, look at what is driving the cost in that market for you today. Is it musculoskeletal? Is it cancer? What's causing the problem? Look at the utilization, PCP utilization, specialist utilization, ER, all those components. Really understand the data. Look at the social determinants of health. Look at climate. There's something that's very important about that concept as well as another form of social determinant. Really ground yourself in data to understand where your problem is and where that efficiency doesn't exist, well, where it does exist. Then start to look at the solution set within that market. We have a tool at WTW called Scout that runs that through all of those components in each market for you, and you can start to see what network solutions are available, what COEs are available in the market, what are the driving causes from the CDC in that market by zip code. All those different pieces are built in. Now you've got your sort of bedrock for that market. Now you can see, who do I want to partner with? Who makes the most sense for me? So when you go out to bid and start thinking about where you want to go, now you're armed with the details you need to be able to make the right decisions. So I'll leave it with that, and I'm turning it over. Yes. Thank you so much. Pam,
I think I'm gonna.
do you need a mic or?
No, let's see. I used to say I don't need a mic because I have teenagers, but they've grown up now. So now I just have my poor husband to work with since he is hard of hearing. But thank you. I want to thank Jeff and the team for inviting me to be here today. I want to talk a little bit about who I am, and because I'm wondering why I'm here too. Sometimes after I hear these great speakers, I'm always a little bit intimidated about what can I possibly share. But I have been on the employer side forever. I'm currently with GE Healthcare, and I have spent over 30 years. And if you go to LinkedIn, you'll see I'm lying a little bit because I really should start to put a 4 in front of that, but we're going to go with this. And I spent all my time either in HR, I've been a generalist, I've ran payroll, shared services. I keep going back to benefits. Every time I leave the benefits function, I go back. I don't know if I have a sadistic streak or if it's just because I really feel like it's something that still isn't working right. I had the pleasure in the early or late 90s, in 1998, to attend a meeting at a coalition similar to this one in Chicago, the Midwest Business Group on Health. At that time, it was in the basement, I think, actually, of the Harris Bank in Chicago. And it was a small group of people, and we were saying at the time we have to do something about cost and quality. How are we going to improve it? And, we're here, 20 plus years later saying the same thing. So I don't know that I have the answers, but I'll just share a little bit of what we are doing at GE Healthcare, what I've seen in my career, and then what we're doing as part of some of the coalition work as well. So thank you, Jeff, for keeping it alive in Milwaukee and making sure that there are forums like this for people to get together. So GE Healthcare, we are not actually a healthcare company. We make healthcare devices. So GE Healthcare is now an independent company as of January 4th of 2023. We were part of General Electric for many years. And we are actually a pretty big presence here in Wisconsin. I lived in Northern Illinois for 20 years, and I didn't realize how many employees that GE Healthcare actually employed here. But we have over 5,200 employees in the Wisconsin area. Over half of them are in Waukesha, and the rest are in the Milwaukee and Madison areas. So we have a lot of people in the state. We have a lot of healthcare challenges in the state. But what we do is we actually make equipment. So we are those bad guys that make the MRIs that you try to limit people from getting. Seriously, we know that, what we try to do is make equipment to make it easier for the clinician. We really are focusing not only on better screens, but then how do you add the AI to that, the artificial intelligence, so that the provider can really sense, does that mark on that mammography require a biopsy, or can that mark really just be something that when we look deeper with better equipment, that's nothing to worry about? Can we avoid some unnecessary care? Can we get better diagnosis? Can we get better care for our patients? So we have about 50,000 employees. As I said, about over 5,200 are here in Wisconsin, and then the rest of our 10,000 employees are scattered around the United States. I have the unique opportunity to work with about 39% of our employees who are what we call field service and sales employees. These are people who leave their house, get in the car, go to a customer. Communicating with them is a challenge. Anyone else who has a large mobile workforce, please see me and help me understand what you can do to make it easier. What I was asked to sort of speak about was our maternity support program. And this is something that GE put in place many years ago with ProHealth in Waukesha and Economowoc. And what we worked on was putting in a direct contract to make the service sort of a locked cost, a bundled fee. And with that, we were able to waive the employee cost sharing. Now, over the years, if you've watched GE, the challenge has been GE has had to, GE stock has gone down, and that means cost cutting. And it means one of the biggest costs that are in part of the business is the benefit cost. So we've had to raise deductibles. So as deductibles have continued to rise, we have been able to hold flat on the program that allows employees to have their babies without having a cost share. It harkens me back to the, forever ago when people had babies for $15 in their HMO, and then when it went up to like $500, they were screaming. Like, well, really, these days it can cost you, unfortunately, thousands of dollars if you're in a high deductible plan. Now, we have this available in several markets in Waukesha and Economowoc, and we work with ProHealth to try to get our families to kind of engage in the program through two pieces. One is called a GE Babies program. And so that's really to kind of connect someone with a nurse. Our nurses with that Evil U health system. I don't want to say their name, but we have a health coach program where the nurses are engaging the employees to say, how can we make sure that you're going to focus on having a healthy pregnancy? Everyone wants a healthy pregnancy. We want it, the employees want it, everyone wants it, but it's not easy. And sometimes we as employers cause some of those barriers when we don't allow people time off to have visits with their doctor, or we have mandatory overtime or second shift and they can't get to their physicians. So besides that, we really work to try to get our folks in the program. The idea is that by working closely with the nurses, we can partner to get them to the most appropriate place of care. We have strong utilization. I think we have an opportunity to improve our high-risk population. We have a program today that really focuses on sort of a normal risk. Many things will create a high-risk pregnancy or a definition of high-risk pregnancy. So we definitely want to start to work on that. We also have across some of our other programs, other COEs in different areas, knee, hip, and spine. We have a partnership with Northwestern in Chicago, And we also have some other partnerships. GE, being a very large organization, had many partnerships where they had large employee populations. So I wanted to kind of add one additional thing I thought that our statisticians here didn't find, which was, I went to Dr. Google the other day, and I was looking at a very interesting article that talked about healthcare costs in Wisconsin. And it ranked, this was a national survey of 180 most or compared to 180 most populated cities across 43 indicators on what healthcare costs were. Milwaukee ranked 88 out of 180. Okay, kind of in the middle, not so bad. The cost of the medical visit, though, and the categories were healthcare, food, fitness, and green space. And we did really good on green space, good on food. Milwaukee has fantastic food. I guess what it was trying to say, healthy food options and good food options. Healthcare was 98 and fitness was 123. So it's hard to get out when it's 27 below zero and you have a foot of snow, but we're working on that. But the cost of the medical visit in Wisconsin for Milwaukee ranked 178. Madison ranked 180, tied with Anchorage and Juneau. Kind of a scary thought. So the cost of the medical visit was very high. The best cost was actually Laredo, Texas, lowest cost of medical visit. Now, if you scrolled through the rest of the different statistics, what I found was fascinating was the mental health counselors per capita. Number 180, meaning the worst, was Laredo, Texas. So you've got the lowest cost place and you've got the lowest access. So what I took from this is that we have to look at it holistically. Of a exam, the cost of some of the nutritional counseling, we looked at it holistically, and that's what we have to do. That's what Centivo is doing. That's what Drew is doing with the work he's doing with his clients, trying to make sure that we're not just focusing on that one point, because that's not going to get us where we need to be. We could go to Laredo and save money. We just can't get anyone mental health care. So thinking about that, I'll just go ahead and end it here. And I know we're going to have a panel, so I'll stop now.
You're on the panel. Yes.
Morning, everybody. I'm Dave Ulster from the Chief Actuary at Centivo, and that means I get to ask the questions. So brought our panelists back up, and I'm going to throw a few questions at them, and I'm going to let any of you folks in the room or anybody online who wants to ask questions throw a few of them as well. We'll have somebody walking around here in the room with mics, so we can hear remotely. But I'm going to start out actually with one for Ashok. And I'm going to, because he's my boss, give him the magic wand and say, okay, here's your chance. You can get employers to do 2 or 3 things you always wanted them to do to really make this happen. What are you going to have them do?
I actually had a magic wand. Is this working?
No,
And then press the button.
it has to be, yeah, at the top.
Hello?
There you go.
There's a green light. Gave it away.
He is not his forte.
If I had a magic wand, I'd have the vision at the age of 22, as opposed to the vision I have right now. I actually think Drew answered it really, really well. There's nobody should lecture employers on what they should do. Every employer has a different culture, has a different workforce, has different business considerations in terms of cost, in terms of affordability, in terms of turnover rate, in terms of type of workforce. But I do think the most important thing is not to chase decision-making arbitrarily because you got a month before renewal coming up. So the most important thing is take a step back, take a deep breath, maybe have a nice drink in your hand, and think about what your goals are. Start with the goals, start with a planning session, trusting whether it's your advisors or other stakeholders. meet some providers in the community to get their perspective. But start with, what are you trying to achieve? What does good look like? What's the scoreboard at the end of the day? And then work backwards. I think those employers who've been very deliberate about achieving goals have managed to achieve those goals, whether it's through a high performance program, through BHCG, through other BHCG initiatives, data warehouse, pharmacy, other initiatives. But too many employers, and for some in the room, too many advisors, treat this as an annual exercise that I just need to get through. That's where we get the bad outcomes that we have.
All right, so I'm taking the wand away from you and giving it to Pam. Let's flip it around, Pam. What 2 or 3 things do you want health plans to be doing that will really facilitate some of this positive change we've been talking about?
Okay, before I start, I do want to say that over the last 20 years, I do think we've made some great changes in the health plans. We get printed documents when we leave, tell us what to do, what not to do, online visits, online chatting with our doctors, some great enhancements. But, the health plans don't make it easy. The health plans, I got an EOB the other day with a denial. I've been in the industry over 25 years. I have no idea why I had a denial. I had to call. And I had to be put on hold, and a 30-minute experience.
He's not on Centivo.
I'm not on Symposium. And
There's
it's
30
and it's-
seconds.
and it is worse because I am almost trying to feed them the answer. I'm trying to tell you what you need to tell me. I'm trying to help you figure it out, but it's not simple. It's not simple. It's very time consuming. We put in processes at employers that make it difficult because we put in prior auths that frustrate the heck out of our doctors and our health systems. And so then what the health systems do is badmouth the insurance companies. So now we have the employee not trusting anything that comes from the health plan because they're the bad empire that has made their life miserable, time consuming, and costly.
That's one of the, if you don't mind, I chime in here real quick. That's one of the reasons why there has been a rise in a lot of the carve-out solutions that we talk about. If you think about, the half an hour phone call, why do you think Accolade and Included Health and Quantum exist today? You talk about people like Centivo. Why do they exist? Well, the bottom line is if the insurance carriers were doing what they're supposed to be doing, they wouldn't exist, right? They're not doing what they need to do. And I think they're getting better. And that's my positive spin on this, right? I'm not going to be here and just throw the insurance companies under the bus at all here, or the carriers under the bus completely. Some are doing better than others in trying to work with employers. Only 5 years ago, if you wanted to bring in a Caram Health or an EDH, for example, or you wanted to bring in an Accolade, they'd be like, nope, not doing it. Run away. Forget it. You've got to go to a TPA. That is softening. That is starting to soften, and they're starting to realize that that is a market they need to be in. Depends on where you are. If you go up to Michigan, forget it. But if you go to other areas, maybe you can achieve something. But I think that is a component of this. And I think Ashok said it really well around, what do you want employers to actually do? It is what I said earlier. It's like ground yourself in the data and really understand where you want to go and create a roadmap. Where do you want to be when you grow up? Where do you want to be 3 to 5 years from now? And then work backwards, to your point, right?
Yeah, Drew, the question I would ask to you is, yes, they're getting better, whether it's competitive pressure or otherwise, but you made a key point. I want to amplify it slightly. You said at least 2 of the large players are de facto unabashedly PBMs, marketing themselves as such, follow the money, profits as such, revenue as such. The other point that you didn't raise is the fastest and most important part of these businesses, which is why Humana exited commercial, to Jeff's point, is care for people over the age of 65.
Yep.
And so my question is, as flexible as any of them might want to be on a case-by-case, issue-by-issue, client-by-client basis, what's going to change the fact that the employer business that they're in appears to be the caboose of their business,
right,
as opposed to where they're really driving resources?
No, I think it's a valid, right? And that's why within what we do, that's why we created Scout, right? Was to bring a light to these issues that they have. Look at the network structures. Before you would go to, I'll pick on Blue Cross because they're easy to pick on, but I'll pick on Blue Cross to say, You look at the Centers of Excellence, it's a great example, right? They'll go on and on about how it's high quality, high quality. But we had no way of validating that in the past. We do now. Data is so available from a cost and from a quality perspective. Now you look at it and you see there's really no value here, right? And we're able to look at that a lot closer now. And that is forcing them. Yes, it is. You could call it the caboose. It's still a pretty significant revenue driver for these organizations, right? And I think that they're realizing now that with the likes of pressure from, which is a compliment from people like yourself, as well as others in the market and from the C-winners, that they're now realizing that we got to bend. We have to bend here, otherwise we're going to become the dinosaur. And the fact that they've so been focused on discount and discount broad networks, that to me is now backfiring. Because consulting community and the employer community is now saying, no, I care about total cost of care now. Now, sometimes we can't necessarily measure it as well as we'd like to, but now we can look at quality. Now we can look at cost. And now it's a little bit different. And I think it's backfiring.
So Drew, I'm going to pick up on a couple of those things because you talked about getting away from the peanut butter approach to everybody gets the same thing everywhere. I know that you've spent a lot of time creating, as you noted, the Scout tool within the WGW world. And I have to admit, as a Towers Watson alumni, I'm actually pretty impressed with what you've done. So I'll give you props for that. But it really has one of the issues that always sits out there when you look at something like a locally specific solution. It takes a lot of work to understand that in the advisor community. It takes a lot of work to really have the inherent knowledge to be able to talk market by market by market, as opposed to a solution that goes across all the people. How do we help and what should we expect of the provider community of the
community under the bus a little bit here because I'm part of it, but we have been guilty of being a little lazy at times. There's no doubt in my mind, right? I'll probably get in trouble for saying that within my own organization, but I think getting the education. I know I can speak to what WTW is doing, right? We're focusing on creating pockets of people around the country who are locally market focused, who understand the markets where they are, and making them the experts within the market. Creating tools that make it easy for them to look at. In the past, they would have to do these huge RFPs. They'd have to study each market. It was very complex. Providing that to them in an easier fashion and a more visibly appealing fashion has really, really helped. It's going to take time, though. There are still those, and it's not just the advisory, it's the employer community as well, who are still. So if I mentioned it in what I was talking about around the whole, everyone in my group has to have the same benefit. And I hear it day in, day out from employers that's how they feel. Because they're so used to, I'm going to run an RFP, I'm going to look at discount. Oh, look, Blue's 2% better. I'll put them in, and then we'll resume normal trend. That's what we've done in the past. And I think we've got a little lazy. Employers have got lazy. Advisors have got lazy in how we look at things. And I think now, the more and more education we can provide, the more and more we can, within WTW and with the employers out there, we can do that. I think we can really shine a light on it.
And get your questions ready. I'm going to go to the audience here in a second. Pam, let me just have you quick react to that. When you are getting support from your advisor group, what are your expectations and have they changed, especially as it comes to this issue of better understanding local opportunities, better understanding things like, the Wisconsin high performance solution and its, primary care focus. What do you really expect from your advisors to be able to move that forward?
I can push on my advisors pretty heavily because I expect them to not only bring solutions for the company, but we need to put the employee hat on. If we can build the best financial program. We could have 150 performance guarantees. We could have the carrier doing backflips for us. If the employee hates it and we have built something that is so complicated that they cannot work, all our management will hear is, you guys are so out of touch with your employee. They think we have a bad program. It's still costing us $200 million a year and it stinks. And guess what? We've got union, papers going around and people are off on disability and not getting the right care. So yes, we need to have great big ideas, but then we also need to sit down and say, now, Pam, in this market, your average employee makes $47,000 a year. we cannot put in a $3,500 deductible because guess what? We might as well have just said, don't get health care. Only go to health care when you have a bone sticking out of your skin, because if you have anything else, don't go. And preventive care, I have to tell you, when you said that, Ashok, about you go get your preventive care and then you get a bill. In 2006, I was working at a company and I had so many complaints about people going to get colonoscopies and then paying $700. 2006, and these are manufacturing. Manufacturing folks must come back from their colonoscopy, get on loudspeakers and tell everyone, don't get it done then, because that's what was happening. No one would go. And so I called up my health carrier and I said, I want all colonoscopies paid at 100%. And you would have thought I was giving away the farm. And I said, I am not going to see abuse. I am not going to see abuse. And we joked about it. And we think we might have had 2 people who abused it. I don't know why.
Who wants to join?
People are looking forward.
And we just kind of joked and said, we think we have to put them into a different program. But you don't get abused because employees will come back and they'll say, oh, you're going for your call. Man, last time I had it, I had 1 polyp. And then all of a sudden I got $700 that I had to pay out of pocket.
Mhm.
And you're going to be like, well, I don't have $700. I have car payments. I have inflation issues. My rent just went up. I have kids in sports. I'll just forget it until it's so bad that now you're my high cost claimant.
Right. You know, 100 million people in America have medical debt. 100 million carry medical debt.
Amazing number.
Right.
Questions in the audience? What brave soul is willing to grab the mic and go ahead and throw a thought out there? Go ahead. Down here in front.
Oh, it's Steve.
No, we don't.
Now we're in
No,
trouble.
no,
Don't
don't
give
get.
him the mic.
I'm sure you can all hear.
Well, online can't hear you though, so
Oh,
wait for the mic because we have a online.
All right, question, I think mostly for Pam, but I'm sure that Drew and Ashok will have comments on this as well. So the question is with all the options out there on centers of excellence, right? You've got every major health plan has their own centers of excellence that we jokingly refer to as centers of pretty good or centers of slightly above average. Then you've got the standalone vendors, the old Bridge Health, Carum Health, right? They've got their centers of excellence program. GE decided we're going to build our own. What was it that you weren't seeing in the marketplace that made you decide it's not good enough, we need to do this ourselves?
You know, part of GE's value many years ago was that it was a couple of 100,000 employees. And so when you are that size and you go to some of these other smaller players, you can be that big, you could be that big gorilla in the room and get your way. So GE was able to do it because they felt like they could get better pricing, they could be more of an influence with the size of both their active population and the enormous number of retirees. So now we are a new company. My 15,000 people, am I going to be big enough in Wisconsin to work a good direct contract? Yes. Am I going to be good enough in the state of Texas where I have 900 people spread across the entire state of Texas? No. So I need a partner when I don't have the size and scope. But I have to laugh because years ago I had this discussion. I had 2 carriers and one had a really tight maternity and infertility center of excellence. And the other one had basically everyone in their network who was a doctor had a star. And I said, well, can you just tell me the best? And they said, no, because we contract with all of them. I can't make anyone angry. So the center of excellence seemed to be a, I had heard that the U.S. News and World Report best doctors, that doctors paid to get on there. I don't know if that's true or not, but so are the health plans really designating people who are the best, or are they designating people who make the loudest noise or who have the better payment plans?
They're also looking at just the facility, right? And they're not going down to the surgeon level. We all know that quality varies significantly within a given facility. A comment with GE, and we're talking about Cincinnati and the Christ Hospital, right? I wonder, it goes back to my point I made earlier around, would they have done that if the Carums and the EDHs and the Bridges had been as significant as they are today?
Back then,
right? Back then it was the only option. Right. Today, I'm not convinced they would do it.
But as a 15,000 person employer, I personally don't have the staff
Mhm.
to work through all the complexity. If I had the size of employees, it made sense for me to build the legal and the contracting and the privacy staff to manage that. Going forward, I'm not going to have the
Right.
capacity.
And from a clinical COE perspective, you need even more volume to
Exactly.
make it worthwhile,
Exactly.
right? How many knee surgeries do you really have? You have to, to your point, you got to have 100,000, right? Whereas, you know, it's a little different from a network perspective.
Let me just follow up a little bit on that, because one of the things that's been an interesting part of the local marketplace here, as we have built out the solution, is that employers have had a little more of a voice in the process. And we've brought employers to quarterly meetings with the health systems. We've had a much more direct dialogue between the provider community and the employer community. You know, you're right, you don't have a lot of time and resource. On the flip side, there's always a question about where do you make the biggest impact. I'm going to start with you, Pam, and have others comment. You know, if you're going to find a place to invest your time, what do you think? Is that a good place to be investing your time? Having that direct dialogue with the provider community?
You know, I think where we have a large scope, I think it is important. I think we want to create partnerships. What I want to see more dialogue with is the health plans with the provider community, so that we don't have this, so that I am not always in the middle of, my doctor said the health plan, you know, really stinks, and the health plan said your doctor's unreasonable. And those are being nice words, because it's usually far worse when I hear it. So I really think the investment has to be, we talk about employee education. I was on the employee education bandwagon forever, until one day it dawned on me, when you get a bad diagnosis, you are totally irrational. You are emotional, irrational. You don't make good decisions. So if I was going to invest in anything, it is going to be in the space where to Drew's point, I am not treating everyone equally. If you have a very serious health condition, I'm going to make sure you get the right resource to help you through it, whether it's a navigator, a concierge service, a guide, a point solution, because everyone has a different need. And that's going to be the most effective, in my opinion, for the employer group. And when we talk about the PCP-based model, I know Jeff and I were talking about it, you know, before. I said, I have always been a huge fan of the PCP model. And it's not because we think that the PCPs are gods. It's because we can go down the wrong path so quickly. I do it myself. I self-diagnose myself. I go to the doctor, like, you don't have that at all. You got something completely different. And it's because, you know, I might start out at a specialist. You know, if I have back pain, I go to a back surgeon. Guess what he recommends? You know, I forgot to tell him that I ate like Mexican food for 7 weeks in a row. And boy, that back pain is actually my gallbladder acting up, or my acid reflux acting up, or the fact that I helped my brother move, you know, so we can go down the wrong paths when we don't have guidance. It's super easy. And we all will pretend, every one of us in here will pretend we will be better consumers when we get sick or a family member gets sick. God bless you if you can. I know I don't.
It gets to the value of high value primary care. And I think we're all in agreement on that component of this. I read a study recently which was really disturbing. And then it was almost 50% of physicians, if they could go back in time, would not be a physician.
Oh.
Almost 50%. That's really quite frightening, right? And a lot of it's to do with
Veterinarians?
You're right, you might make it the vets. But that reminded me of that when that was being mentioned. But it's terrible. It's really, I think a lot of it goes back to the HMO days and the way they were treated back then. I think a lot of it is to do with burnout. There's so much going on within the primary and giving more value to primary care physicians. I also think we underpay them. You know, for the value they bring, I think they're underpaid.
Yeah.
Check see if there's any other questions in the audience. Because otherwise, I'm going to, you know, ask my actuarial question. So,
Right.
Yeah. Go ahead. There's a question in the middle here.
Where's it going to stop? Like,
It's like the
Yeah,
Olympics.
for those of you who are not in the room, it's sort of like clear coming across the baseball game. So,
All right. Hello, my name's Emma Holme. I'm with Navitus. I have a question for Ashok. As far as kind of a hot topic right now is weight loss with the new GLP-1s and all the prescription options that are hitting the market. I kind of wanted to get your opinion what Centivo has seen from like the medical provider stance, as far as gastric bypass, is the gold standard. Do we see providers now looking to adopt more of these prescription products that typically employer groups do not cover historically?
Yeah, so thanks for the question. So we've not had it come up proactively as a topic. I've definitely seen and felt a fair bit of chatter on LinkedIn and otherwise. And, one thing before we get back to the sort of Ozempics of the world is it is incredible if you look at any pharmacy claim report. I'm no deep expert on drugs and compounds, but I have heard about every drug that you see on a top 10 report because I watch football. So the correlation between direct-to-consumer advertising, when I worked as a management consultant many years ago, actually Pam worked with the organization many years ago, we can have that conversation. But one of the things that we would advise healthcare organizations on was get people to ask. Because if you get people to ask, you will stimulate demand. So that's certainly a, it ties to both weight loss and other categories. I think generally speaking, there's a place for everything. Drew talked a lot about appropriateness. I don't think any of us would say a gastric bypass is unnecessary or should be hard to get, or that a hip replacement is unnecessary or should be hard to get. But I think what we all are touting is if you have a trusted relationship, starting with primary care, the right team of specialists, that decision and that information needs to be well informed, and that conservative care approaches might get you the same result with a better quality of life, let alone a lower cost, than immediately going to a drug or immediately going to a procedure, which, let's face it, is a very American way of thinking of healthcare. There's a lot of conversation right now about a theme, known as food as medicine, and taking some very hard looks at what we consume. And the reality is our diet stinks, and we eat tons of processed food. And there are ways to avoid a lot of the things that we're doing. They're hard, but they're conversations that need to happen. So I think from a policy perspective, to your point, we'll continue to keep our ear close to the ground on what providers want, what employers want. As another point on that, we actually reduced our pre-certification list by over 50% when we looked at the data, and MRIs, for example, no longer eligible for pre-certification because we took the approach that if you trust the provider, that the right things happen 99.9% of the time. And so I think we'll follow that approach specifically on this. But look, everyone is going to get their clocks cleaned by the pipeline of biologics that are coming down the pike at every big drug company, unless you're paying attention.
So since you raised the word data, I'm going to ask a quick question here.
Oh, we have a question.
So to follow on to that question, you do have an organization here that's locally based here in Wisconsin, and we are the first and only approved medically tailored meal provider and part of the food as medicine movement with an employer and employee benefit offering. My question is, do you foresee, being local here in market, potential partnership opportunities really underscoring that movement and the efficacy of the power of food as the most efficacious intervention to truly eliminate diet-related disease, to be part of a plan design?
So I showed my cards. I think it's really important.
That's my question.
But it goes to where this whole conversation started. So Centivo will entertain pretty much any partnership as long as it's in the best interest of the employer community, the providers with which we work, and it fits with the objectives of BHCG. So in terms of if anybody, whether it's food or medicine or as medicine or anything else, has a good idea to advance those goals, the person you have to convince is not me or anyone on our team. The person you have to convince is the right stakeholders at the BHCG. But I would say, from my knowledge of how they think, that this is exactly the kind of approach that they would embrace as well.
And if I could add on, 25 years ago, we would cover a nutritionist one visit if you had a heart attack. So we as employers need to embrace the idea that if we want people to have good nutrition, that we can provide, yes, they can find a million apps, but they're very general. So if you want very specific guidance on nutrition, we have to be able to allow people to see a nutritionist and be able to develop a plan to manage their health. And that has to be part of a plan design.
I think we've created a model here in the States that makes it very difficult. Ashok made the comment about watching football. I'm watching Premier League normally. But the same adverts are running, right? Same thing. And the fact that we have those direct to consumer adverts makes it really, really challenging. It's a pill for everything. I personally believe they shouldn't be up, period. I think it should be up to the physician to make those calls.
Socialist.
Easy now. But the fact that we have those adverts, like I live in New York, you can't, I mean, every advertising break is health system, a drug, it's constant. You're bombarded with it, right? And when you are overweight and you go to your primary care physician, if he says, well, go for a run and eat lettuce. You say, well, can I have that pill? I just saw it on TV. That's what the problem is, right? There was an interesting study done in my home country of the UK. I'm familiar with during World War II, there was rationing around at the time. And they were able to study when they came off of rationing because sugar was rationed. So they were able to do a huge longitudinal study over the course of 30, 40 years of the impact of that sugar. And it was remarkable, the health differences that happened as soon as it came off of ration. So it's not just a United States problem, it's a world problem, a Western world problem around those type of things. But as long as we continue this profit environment, the way the drug companies operate, the way all those things happen in this country, it's going to be really challenging to change it, unfortunately.
Any other questions from the audience? We're here in the middle.
Hi, Tom with Centivo. We talk about getting more money to primary care. I would open it up to anybody in the room on ideas on that. I know several years ago we tried capitation. Do you think that could come back?
I think it could. I think there's a potential for it, and there are certainly models out there that are moving towards that. I'm not a primary care physician. I don't know the reaction of the primary care community. I know you probably talk more to providers themselves than I do.
As an employer, it scares me. It sounds
Yeah.
like we're going back to the HMO. And the HMO had such a negative connotation because it was focused on cost savings. In fact, Drew, I made a little note.
What did you say?
You said narrow network, higher quality, and lower cost. I would like to say appropriate cost. I'd like you to change that because lower cost is good, but it's really got to be the appropriate cost.
Right.
So that's my worry with it. When I hear it as a employer, I'm going to bristle when my consultants tell me that they want to put in capitation because I'm going to feel like that could limit getting someone the right care.
I
It
think
could, not
but-
will, could. And that's the perception and the employee perception problem that I always try
But
to
knowing
deal
we
with.
have so much better information now,
Yeah.
I think is a difference.
I think
It-
there's two things that are different right here. One is in the old HMO days, one of the biggest problems I think it was is that the PCP wasn't the gatekeeper, the insurance company was.
Yes.
That's a problem.
Correct.
Right. When the PCP has control, I think it's a little bit different. And to your point around the data, we can now measure and reward physicians for doing the right thing, whereas in the past we were unable to do that. So I don't know. I don't know which way it goes. I think the whole primary care model is ripe for change. I think the idea of patient-centered medical homes in a form where you've got panels. You talk to young people today, they don't have a relationship with a PCP, and honestly, they don't desire to have a relationship with a PCP. Right. But giving them a medical home, I think, is very important.
Yeah, and I think to reconcile some of the views, a good stepping stone, and we're getting demand both on the employer side and the provider side, is the notion of some call it direct primary care, a PMPM, subcapitated, some people call it, but it's really defining a primary care payment model that in the words that are often used is help me pay the bills for non-visit based compensation. So whether it's 30, 40, 50, 100, whatever the number is, PM, let's get past the, I'm going to charge $15 every time I log into Epic to communicate with my patient. Let's get past the, am I supposed to tell you to come to the office because then I can code you for an office visit. Whereas if I can get this done over the phone, I feel like I'm taking it out of my hide. So I think because of digital acceleration, virtual care, other types of models, we do need to move more aggressively, and we are starting to do this in a couple of places. We do need to move more aggressively to basically taking that primary care layer and potentially rolling some other things into it, low-cost medications, basic labs, imaging, into something that is quote unquote capitated. But I think that is quite a stepping stone, a bridge far from here's $15,000, do as you please.
So I have a question from an individual that's participating virtually for Ashok. So does Centivo have plans across the U.S. or is it only centralized in Wisconsin?
I would say the beating heart of Centivo in a lot of ways is here in Wisconsin, but we are in 12 markets, including a number of other large metropolitan areas, New York, Dallas, Denver, Southern California, Orlando, and others. For us, we start, and our consultant, broker, advisor partners are critical in this. We start with, can we add value? Should we add value? If it's a market that is heavily dominated by a single provider system, by a single payer, our ability to add relative value is probably less. But if we have an engaged employer community, an engaged provider community, high cost, the opportunity to bring value, that's where we look to plug in. So it's certainly across the country, but not everywhere.
I know we're over time, but when we get a panel like this, it's hard to let them go. So just one more question that I'm going to start with you, Drew. And this marketplace has been a bit unique because the employers did something that employers typically don't do. They went out and did their own data study. They went out and looked at primary care and said, we're going to evaluate it. We're going to commission a study. We're going to control the study. We're not going to wait for the health plan to do it. We're not going to wait for somebody in academia to do it. We're going to do something different. And then once we get those results, if they matter, we're going to build a solution around them. My observations, that doesn't happen very often. I'd be interested in both your observation there, but also you've seen some of the results. Give us your unvarnished view. Is it the right way to put together a solution?
Way to put me on the spot. I applaud what's happened here in Wisconsin for sure, right? I think that more employers and employer groups need to look and dive into markets more. That's part of the reason why we built Scout in the first place, was to have employers have the ability to dive into those markets. And I think what Centivo has achieved here is remarkable. I think it's really, really, really strong. I'm a consultant. Every time I see numbers like 23 to 36%, I go, really? Right? I mean, that's just who I am, and I'm always going to be that way. So I'm not saying it's not true, but I think sometimes employers and the community out there is going to have a heavy dose of skepticism, right, around those results. And I think I encourage employers who put in these types of solutions to measure. That's one of the biggest components of this that they don't do, is they'll put a solution into place and then let it sit. And you got to measure. You got to keep measuring like you guys have here, and that's really, really strong, and it's really good. And those savings could be anywhere from 10% to 40%. And I believe that's probably a possibility depending on the population, depending on the market, depending on how risky that population may be that's in there. But the actuary in me, I'm sure you're always the same way there, Dave, is that you immediately are skeptical and you immediately want to dive into the data to understand it. But I have no doubt that it's driving strong results. That's what I will say. It's something that I think is a positive, and I think in every market where I've seen Centivo operate, we see positive results.
So Jeff, I'm going to ask you if you want to wrap up real quick.
Yes.
Oh, you found your phone. That's good.
Yeah. Absolutely. It's terrifying. first of all, I would like to thank all of you who have participated either in person or virtually today. Truly do appreciate your participation. And obviously, an immense amount of gratitude and thank you to Pam, Drew, and Ashok for joining us. I think they've been not only incredible presenters, but even more so from the panel standpoint. And also Dave. And Dave, the one aspect, full transparency, that Dave failed to mention is Dave has been for over, it's been a long time, for over 20 years, the strategic advisor to the business healthcare group. So again, full transparency. So I would like to take you back to one slide very quickly, because I failed to point this out. So at the very bottom of this slide, there's a reference to Wendell Porter from Healthcare Uncovered. I don't know if any of you have ever read any of his posts, but if you have not, I would highly encourage you to write down and look at what Wendell posts. He is an incredible resource and expert when it comes to healthcare. And as a matter of fact, his post today, which I find to be incredibly not even sure what the appropriate term might be, but unbelievable because of what we've been speaking of. So the headline is simply this, and this is what I'm going to leave you with. Health insurers have spent over $141 billion buying back their own shares while premiums and deductibles have skyrocketed. How have they been able to do that? They've been able to do that on the back of you as employers and your employees. So think about that. Traditional, let's contrast that with Centivo. Not going to happen. So thank you very much. Have a great day.
Thank you.
Thank you.
I